So due to all these properties interacting, oxygen diffusion in normal circumstances is what we call perfusion limited. If the diffusion system is working perfectly, you're only limited by your ability to pump blood through the lungs to pick up oxygen. However, pathology in the lungs can make oxygen diffusion limited. And here we can see the equation for oxygen consumption based off of cardiac output, which is our flow or our perfusion, which is times the arteriovenous concentration difference. Diffusion, as we discussed, can be challenged by exercise, alveolar hypoxia, which we could see here in the difference of partial pressures, as well as thickening of the blood-gas barrier. The other thing to consider that we just discussed is that our diffusion can be affected by its reaction rates with hemoglobin. Normally, O2 forms easily reversible combo with hemoglobin, and 1 gram of hemoglobin carries approximately 1.39 milliliters of oxygen. The amount of O2 carried by the hemoglobin increases rapidly up to a PO2 of about 50 millimeters of mercury, and then flattens out. Saturation of hemoglobin is the percent of the available binding sites that have O2 attached and is given by the equation O2 combined with hemoglobin divided by the oxygen capacity times 100. So arterial blood with a PO2 of 100 millimeters of mercury is about 97.5% saturated. And just a reminder that the mixed venous blood is going to be about 75% saturated, which equilibrates to a partial pressure of 40 millimeters of mercury. So when we discuss oxygen delivery mathematically, we can represent that in an equation. So oxygen delivery is going to be 1.39, which you remember is the ml of oxygen carried by 1 gram of hemoglobin, times the hemoglobin, times the arterial level of saturation, times our dissolved O2, times, of course, our cardiac output. This curved shape of this dissociation curve has advantages. At the upper level of the curve here, very small drops in PO2 do not affect hemoglobin loading very much. However, once you dip into the steep part of the curve is going to augment offloading with only small changes to the capillary PO2. This can be both good in times of increased need if the system isn't overwhelmed, but it also shows that once you dip into the steeper part of the curve, it can be more difficult to regain ground and compensate in the face of pathology. This curve, as we remember, is shifted by a number of factors, including temperature and pH. So now we need to talk about the second function of the lungs, which is CO2. So CO2 is carried in the blood in 3 forms: dissolved, bicarbonate, and carbamino compounds. And they equilibrate via this equation. The first part of the equation is very slow in the plasma, but is very quick in the red blood cell because of the presence of an enzyme. The second reaction is ionic, and so its dissociation is very fast. CO2, as we remember, diffuses approximately 20 times more rapidly than O2 because it has a much higher solubility, but does not have a significantly different molecular weight than oxygen. When we discuss ventilation, we need to remember that it is distinct from oxygenation, but it is also inextricably linked to oxygenation. Ventilation is one of our primary forces of driving our force of breathing due to the solubility of the CO2 in the blood, which we saw, and physiologic sensors which operate off of the CO2 dissociation products, such as hydrogen ions. It's important to understand that ventilation pathology can also affect our oxygenation and can contribute to difficulty maintaining adequate respiratory saturation and oxygen delivery. It's also important to note that different parts of the lung ventilate differently, and that you can have differences in our ventilation to perfusion ratio and inequality. These are termed west lung zones, and in their VQ proportions proceed as follows. The first and second parts of the more cephalad part of the lung, we can consider that usually our good lung, and especially during times of pathology, zone 3 is going to be more our edematous bad lung. The ventilation by V and perfusion, represented by Q in zone 1, is going to be greater than 1. You are overventilated, in part based on gravity and also in part based on height in the lung, where you have increased distension of our alveoli, which allows or causes some compression of the perfusing capillaries. In the second zone, we have our ideal part of the lung, where the ventilation and the perfusion are balanced. In the lower part of the lung, we have increase in perfusion and less distension of our ventilation. However, due to the increased forces from perfusion, if you can recruit this bad area of the lung, you have the most to gain in terms of ventilatory capacity. Simply by distending these alveoli more, you can bring them much more easily up to a VQ of closer to 1.